So I wanted to briefly talk about spine trauma injury assessments, and this is not a lecture. I invite each and every one of you to interrupt me at any given time. I don't think I have any commercial conflicts to declare. And just briefly, the conflict I have to declare is I work for Swedish now, and this is part of the Providence Healthcare Network. It's actually now 52 hospitals up and down the western US, and this is a hospital that is dedicated to brain and spine surgery. We have a heart unit here also, but that's it. There are pros and cons to that. We have a huge surgical volume. We don't do polytrauma, that goes to Harborview, but we do trauma here. We do spinal cord injuries. We have, just this weekend, again, we had several tumor patients and infection patients, and they basically get flown to us, so we do nothing but that. But it's over 3,000 spine cases a year, and I don't know the craniotomy numbers and the vascular numbers. But so it's kind of cool to be in this kind of a setting, but at the same time, it's easy to lose perspective of what the needs and the problems are in other facilities and places. But this is a new model that's emerging in the US where there are just dedicated hospitals for certain areas. And I think you in Delhi, right, Tarush, you have a similar setting now. It's happening more and more there. So there's the Ganga Hospital, there's your Delhi Hospital, and you basically just do spine there, right? So I'll reflect in about 25 minutes on what I think is what you really should and would need to know for simplified classifications, realizing that you can spend days getting lost in classifications, timing of spine trauma interventions, and present some principles of fixation and learn from your experiences. And I'll say it very, very clearly, and this is why I'm a spine surgeon. I was a trauma surgeon in the beginning, but we're changing lives. We're not just saving lives, we're changing lives, and the spinal column is one of those absolutely defining organ systems, I think, I dare say. It's not just a musculoskeletal structure. It's a complex organ system that helps us function. That's a drama. So there's very little doubt about the preeminence of the spine in terms of the function, and it's obviously a complex structure that is unique in its anatomic alignment and need for dynamic stability, whilst it serves as a conduit for neurologic and vascular structures. And yes, we now have, if we have these neuroimaging availabilities present, we can now really see the spine in its structural integrity in an unprecedented fashion very rapidly. If we fail, patients are usually in misery, and again, that is very well identified now. So patients with a failed spine have the same outcomes as patients with severe end-stage cancer, if we quantify that. So the outcomes of a failed spine are miserable. Do we really need all this new stuff with minimally invasive surgeries, or O-lifts and X-lifts and beautiful X-ray suites? I think not. The proof is still very much missing, and I know Dr. Drazin, who leads a national course on minimally invasive surgery, he's crunching his teeth. That gnashing sound is his teeth gnarling, right? But I really am not sure that we absolutely need this. If you have a good indication for surgery and do it solidly, patients will be very happy. If you do it through a keyhole, everybody's even more happy. But you know what? If you do it like this, the patient will never know the difference. Back to the basics. You saw something that I just love. This started at Harborview, this realization of doing the draping sheets and resuscitating patients, not with some complex clamp and this and that, but putting a bed sheet on a patient rather than the mast trousers, which I was born with and raised with. This is a classic example of what I love about trauma surgery, going back to the basics. Always think about your resources and what you have available, and you can do so much with relatively little. And it's actually probably arguably better. Pertinent to trauma care, the most efficient treatment came probably from Sir Ludwig Guttmann, who basically postulated recumbent care for spine trauma. And that is a reality in many places around the world. And it's a interesting perspective because it's, again, if you think that trauma patients are disabled for a long time, for spine patients it's 3 to 6 months plus. And it also has a very significant risk with it. And I remember that I was trained in Munich, Germany. You can probably tell by my accent, I'm not from here. And we had a postural treatment unit. Back then, non-operative care in about 82 was still very common for neurologically intact patients. And we had a lot of skiing injuries in Munich. And so we put these young men and women into casts and laid them down and did a postural treatment. And every springtime, when the 3-month magic mark came by, we'd mobilize these patients, and there'd be routinely 1 or 2 patients who'd keel over the second we got them up, and they'd have a nasty PE. And so these are actually very complex opportunities. And when we do non-operative care with recumbent treatment, it is powerful, but it's also a very detail-oriented undertaking. It's not just keeping a patient at bed rest. So it's something that in our country is actually unaffordable now, pretty much. We can't afford keeping patients in a hospital for 3 months. It's way cheaper to do complex surgeries and getting them up and trying to get them out of the hospital in 2 days. It's way less expensive than keeping a patient in a hospital for 3 months. So what are the outcomes of spine trauma? Deformity, pain function, spinal cord injuries, and death. And again, I was raised, and my fascination in spine trauma arose out of my experience in trauma care, which preceded that of spine trauma care, where we worked all night to get patients ready to be mobilized, just to have the spine doctors come by and arrogantly and say, oh, just keep them at bed rest for a couple more days. And yes, technology is making great leaps and bounds, but again, there's little to say to this picture than the profound frustration this patient has and not being able to move, but at the same time also the hope and the power of the human mind, with this patient still having some quality of life to try to express himself here in terms of his well-being. In our country, basically, spinal cord injury is a very prevalent problem, increasing an aging problem. Gunshot wounds are the still leading cause, and we can talk about those tomorrow in cases. But the suffering is, again, very, very difficult to contribute. And again, there are new things happening. In Bochum, we have Dr. Fiesan here from the University of Bochum. The neurorehabilitation, the robotics are making great leaps and bounds. And I'm actually quite happy to prognosticate that within 10 years, many of our countries will have a way better way of mobilizing spinal cord injuries than we ever had with actually affordable neurorobotics. But back to where we are here. So my suggestion is to go back to simple basics and use those and apply those. And again, they're actually in the AO spirit, and hopefully they'll become a science spirit with your help and your input. And that's what we're looking for. So as to diagnosis, treatment, education, implementation, and continued refinement, the lessons of Dr. Zirkel, I think, are very applicable. Let's start with the most controversial, simple thing in spine. What is spine stability? I'm not going to give you the lecture of Drs. White and Punjabi, which is so legendary. It is a combination of clinical examination and radiographic evaluation that then presents this clearance of a spine. It is so difficult to do, and it is so important to do. The best example in spine trauma for me is basically this picture here. What am I showing here? I'm going to walk around with a microphone. What is this picture showing? This is showing a palpation of a back. It's showing an AP and a lateral of a spine. Does anybody know what injury this is supposed to show, what the meaning of this is? Who treats spine trauma? Who's willing to take a lead here? All right, I'll come to the middle. I forgot your first name, so please tell me your first name. Remind me of your first name.
Yeah, my name is Anthony.
Anthony, hi.
Yeah, fine, thank you. I think it's trying to demonstrate a disruption of the posterior ligamentous complex.
Bingo. Right there. This is a classic, thank you, spot on. So this is something that's overlooked, and again, in our UW medical school classes, this is something that would drive me nuts, but patients would not be rolled properly anymore. There'd not be a full palpation from skull base to the occiput. There'd not be a proper rectal exam done. And again, this palpation is more meaningful than any MRI scan. We spent a lot of money and a lot of studies trying to see what MRI sequence will show us conclusively if that PLC is actually torn or not, when in fact a posterior palpation that has a gap, ecchymosis, crepitus, anything like that can show you way more than is necessary. And we'll talk about this injury later. The classic on the AP and lateral X-rays you'll see later, but you basically see something that looks like a compression fracture. The key thing is there's a gap in the back. Why do we miss those so often? They usually happen at the thoracolumbar junction. If it's in your hospitals, like in our hospitals, we usually get a thoracic and a lumbar spine X-ray, and we miss the thoracolumbar junction, although half of all injuries happen at the thoracolumbar junction. It's a classic case of spine clearance. I'm not going to read through this, but one of the key things that I hope you have and that you'll develop and bring back home. It's a simple structured sheet, and I can give you one from a printout if you have an interest of that, of our EMR. Our fellows have a simple menu in our electronic medical record of the key neurologic exam points that they can basically check off. And this is very important for tracking, for quality control. And again, it's actually simple to do. It's relatively fast. Would you agree, Tarush? I mean, how long does it take you to complete the neurologic eval form?
5 minutes.
Yeah, it should be 5 minutes, but it's so important for documentation purposes. You should be able, from your clinical examination and from your radiographs, determine a neurologic level of injury and a skeletal level of injury. And why is that so important? If there's a discrepancy of the two, you have a problem. And this is where you have to put on your Sherlock Holmes cap and start, get your pipe in your mouth and start thinking very heavily, why is there a mismatch? Those are the two problem actors. The other thing, and this is a derivation of Dr. Cleveno's excellent talk before, why rolling the patient under spine precautions is so important. It's identifying the posterior contusions, and especially a variant of that, the Morel-Lavallée lesion, which is very common to the posterior thoracolumbar spine and impact trauma, where there's a true deglovement of the lumbodorsal fascia that Dr. Tubbs showed before from the muscles. And this has a huge implication in terms of any posterior surgical applications. That's something that we can ask our Harborview colleagues in terms of their tips and tricks of how to handle these terrible deglovements. Who of you, by a show of hands, has seen that? Who's seen a Morel-Lavallée lesion? About half of you. And they're terrible, right? I mean, very challenging. In terms of the neurologic examination, I'm not going to bore you with the details. We can talk about that, obviously. I defer to the Asia categories, and I think that's a globally accepted, very meaningful thing. My points here are that not every spinal cord injury is complete, and these three elements show the preservation of a spinal cord which offers the hope for recovery. If you have perianal sensation, if you have an anal sphincter tone, if the patient can move their big toe, that is called sacral preservation. That is a patient who has the miracle of recovery in their hands, and that's in your hands if you do everything right. So making sure that these three elements are identified is a very big diagnostic step. Again, I don't know how it is with you. In a large medical school in close proximity here, Connor knows what I'm referring to. It is a very common phenomenon. It would drive me nuts to look at a history and physical of a patient and see rectal exam NL, speaks for normal, written down by a medical student, and nobody had ever checked it. And a medical student has no idea what to do. So the rectal examination is really important in a male for prostate, for blood, sensation, light touch, pinprick, distribution patterns, and then spontaneous tone and voluntary best effort tone. It's not rocket science, but for spinal cord injury care, it's hugely important. And then if you have questions, you want to go for the reflexes and, again, educate people on reflexes. To the present date, when I have residents with me, I can flip them and make them very uncomfortable very rapidly by talking about the bulbocavernosus reflex. They don't know why and what that means. And it's one of those challenges in terms of education, because the neurologic exam is sadly something that's not commonly practiced, when in fact I think it's very simple dimensions. Now, this is the problem of conventional imaging, and a lot of us have this problem. We have this problem in outlying hospitals. We have kind of all these zones which necessitate and take a lot of time. For X-ray techs, they swallow a lot of time for a trauma patient, because if we do a full workup in a US hospital of all these images, it's 45 minutes. 45 valuable minutes that are lost, 45 minutes of work time for an X-ray tech or two to get all these images done. And then frequently we have problems with limited image qualities. But I realize that a lot of this is necessary for our care if we don't have CT scans available. So it's still relevant for alignment, for screening. And again, the transition zones, specifically the cervical-thoracic junction and the thoracolumbar junction, are frequently not well captured. Do we always need APs and laterals? That's my big question. Probably not, quite honestly. For the cervical spine, if we have no CT, a lateral is probably very good. And getting a shoulder pull down or a swimmer's view. For the thoracolumbar spine, I'd just get laterals and only order APs if there's a specific question. I know it's not textbook, but in a bind, this is way more important than anything else. Now, medical students and young residents always shriek when I show them C-spine X-rays and ask them to interpret that, when in fact, the principles are very simple. Is it an adequate study? What's the alignment like? What are the intervals and the integrity of the structures and the angulation? You can just go through this mental checklist, and all of a sudden, these students will become much more eloquent in how to do this. Again, why just get a lateral C-spine X-ray? For the majority of patients, a lateral C-spine X-ray, to include C7 or T1, is actually perfectly satisfactory to pick up the majority of major injuries and relevant injuries. CTs, who of you has a CT scan in your trauma center by a show of hands? Who can raise? Do all of you have a CT? Not all. So CTs are obviously a game changer. And nowadays with modern software, it's mainly a software problem, and detectors, you can get whole body CTs in a matter of 2 to 3 minutes. In our country, they're about $250 now, so not getting it is a problem. But again, this is more modern software, but these are actually money savers. And if they can be instrumentalized in your countries and your health systems, that's a huge improvement for quality of care. It saves money, actually. And they're actually very reliable machines. So we get these on patients who are cognitively impaired or at-risk patients. We have a lot of elderly patients. And for young children, it's way better to get a CT scan than to get X-rays because they're way faster and they don't have to lie still. Of course, we want MRIs in an ideal world. Who has an MRI scanner by show of hands? So that's where we get thinner. Do we absolutely need an MRI scanner? No. It's very important, obviously, for research, for understandings. But this is a dislocated patient. And you know what I'm saying about this MRI scan? I don't ever want to see this MRI scan again. Do you know why? This patient should have been reduced before this MRI scan was obtained. This cord is obviously extremely traumatized by the ongoing dislocation. And we'll talk later about reduction. I want to see this be reduced. And even if it's not reduced, I want to see the canal cleared so this cord is disimpacted, and then get an MRI scan. I don't see any therapeutic benefit in getting an MRI first with this kind of a picture. So we can obviously see soft tissues, discs, ligaments, but all these things are kind of a luxury. If we have the technology, we should use it. If not, a good physical examination and attention to details on plain films will do the job just as fine. So there are a lot of rules and regulations associated with spine surgery, and that again makes it very perplexing and intimidating to a lot of people. The problems are, again, we have many different problems with our classification systems. They're not easy to remember. There are way too many subcategories. And again, there are many problems behind this. There's egos involved. There's research involved. There's an ongoing refinement. To me, what really matters is the following 3 things. How much energy was imparted on the patient? I think our Harborview colleagues with the pelvis group would agree. This is probably the single most important thing. What is the relationship of the energy imparted on the patient and how healthy was the skeleton that received this? What was the injury load and what was the baseline host condition? Those are the 3 factors altogether. So again, we see basically major differences between high-speed injuries on the left. And again, we see insufficiency fractures in elderly patients with far less injury impact on the right side. And again, in our country, it's a sign of our increasingly aging population and poor health. We see far more insufficiency type low yield fractures. So injury load and getting an understanding of that and putting that into your assessment is a huge deal because it has ramifications on other organ systems. And for us as orthopedic surgeons, the lungs are the primary target of secondary injury loads. Again, I can't overemphasize the importance of a physical examination, and especially looking at occult soft tissue injuries, the rectal vault, the vaginal vault, and looking at patients who have coverage on. This is an old MAST trouser. These were these are compression hoses that we had on. It was classic that injuries were missed because these patients had these compression hoses on. We have to take those off when we examine patients. So let me just pop through that. So one of the most important things that I can think of is basically going back to the basics of the AO classification, A, B, C. This was so simple, it's so elegant, and it kind of got botched because there are multiple subcategories. The Swiss, the Germans, the Austrians just couldn't help themselves. They had to kind of categorize every single thing, and it is meaningless. A, minor fractures, B, bending injuries, C, circumferential injuries. So laminar fractures, spinous process injuries, compression fractures, they all fall into A's. B's are bending injuries, forward or extension, and C are dislocation injuries. And then we can basically go into severity scoring at a point scale to the various numbers of severity of structures, like in the cervical spine, left and right facet joints, PLC, or the anterior column. Same in a similar fashion for the lumbar spine. In the neck, again, the lateral X-ray cannot be overemphasized, and I still like that a lot. If we have more than 11 degrees angulation, that tells me that there's a potential for instability there. If there's more than 3.5 millimeters translation of the end plates of the posterior walls, that's a risk for instability. The classic injuries that we see are the unilateral facet dislocations, and again, I recommend that we stay with these common terms where one facet joint pops out. They have less than 25% dislocation, but you have to look carefully for the joints. It's usually a rotational injury, so a root injury is way more common than a cord injury. It's very common to have a disc herniation with these, but these are rarely cord impacting. So that's a very classic injury. The ideal treatment is actually controversial. Most of us will treat these surgically nowadays, but non-operative treatment in neurologically intact patients is actually not unreasonable. And we can talk about that in greater detail. These are just some treatment options. The other factor to point out are bilateral facet dislocations. So this is where both joints pop out. We have more than 25% translation. These are actual dislocations with or without a fracture. Spinal cord injuries in these patients are very common. You just saw an example earlier on the MRI scan, and these are always unstable. And my suggestion to you is, especially hopefully emboldened by the training here, you'll feel happy and comfortable to treat these patients. You can make a huge difference in the outcome of these patients by operating on these patients and knowing the basic anatomy, and with actually very simple tools and implants can make a big difference. These are pictures from 1992, and they show basic implants that we used back then. And again, this is all we had back then, but you know what? I don't think we have any better outcomes nowadays with modern implants than with those. Interspinous ligament tears, those are again tears where the PLC in the cervical spine tears. They're obviously secondary injuries to the facet capsules, for instance. These are actually a very interesting injury that happens in younger patients usually. They're always unstable. Doing a simple surgery there, we can talk about that separately, with interspinous cables is a very reasonable treatment option. And then bursting injuries, an axial loading injury where the vertebral body itself plus minus facet joints gets injured. Those are injuries that we want to recognize as a separate entity. They usually require some traction, a reduction alignment, and then a decision for definitive surgery versus a non-operative care with a halo or a brace. In our country, and I don't know how often you see that, we're seeing more and more extension injuries. Who has ankylosing spondylitis or disseminated idiopathic skeletal hyperostosis? Do you have those in your countries? Do you see that in India? Do you see this in Pakistan? So this is an increasing phenomenon. We don't know why. Aging has something to do with it. Genetics have something to do with it. It's an inflammatory/genetic condition. And again, the problem is, as you know, the spinal column becomes very brittle. It's far more susceptible to simple falls causing major injuries, and spinal cord injuries are very common. Recognizing them is a big problem. In our country, it's a big source of liability because if they're missed and patients become paralyzed, there are major lawsuits that happen very rapidly. So these are very common in our country nowadays. For the thoracolumbar spine, my main first observation suggestion is to look at the patient as being either a healthy individual or an osteoporotic patient. The second injury focus should always center on the thoracolumbar junction. As I said earlier, half of all injuries are in that area. And so if you do an X-ray screen, for me, a lateral thoracic spine, a lateral thoracolumbar spine, a lateral lumbosacral spine is probably as meaningful as anything. And to forget the APs in the beginning. Variables are the rib cage provides a lot of stability in the thoracic spine. An extremely vulnerable, extremely meaningful structure, the conus medullaris, lies in this focal injury zone. And again, it's very easy to have permanent bowel, bladder, and sexual dysfunction with injuries in this area. The cauda equina carrying vertebrae are far more forgiving in terms of misalignment and neural canal compromise. How do we label injuries? Again, there are multiple expressions, but going back to the Anglo-Saxon tradition of simple words, I think we can just do a lot and agree internationally on these words: compression, stable burst, unstable burst, the bending injuries as in chance, flexion distraction injuries, and then fracture dislocations. And there's actually a great logic and a great therapy correlation with these injuries. Compression injuries are a wedging of the vertebral body without any invasion of the spinal canal. The PLC is intact. The patient is neurologically normal. Those are the main factors. And again, the big variable is how many levels are involved. This can affect young people as well as elderly people. If it's multiple levels, you may have to think about a brace. If it's one level, you can see how the patient does with the magic of physical assessment, which is getting the patient up and seeing how painful they are. A stable burst fracture. Now, there are many books that write about percentage figures of canal compromise and this and that. This is pretty much irrelevant. What matters yet again is the physical exam finding of, is the PLC intact or not? Is the patient neurologically intact or not? And what happens to the patient when you get him up or her up? If a patient is fine laying down and grimaces and is in pain and sweats and has expressions of pain when they're up, that is unstable right there. And you can modify that by putting a patient into a brace or a cast and repeat that same test. If the patient cannot get up right in front of your eyes, you have an unstable injury. And you have to think about plan B, surgery. So this is an example of a patient who we actually treated in a cast. This is a horrendous 50% canal compromise. The patient was just fine and had no problems mobilizing in a cast. An unstable burst fracture is the opposite. So yes, we have research, and we did that in our lab. If you have more than 50% loss of height in the vertebral body, they're probably not going to be able to tolerate non-operative care. Any form of neurologic injury, regardless of how much comminution, how much canal compromise there is automatically an unstable injury. One plea that I have, it's a plea that I continue in our own fellows, is let's forget about this 3-column system. Do you all know about the 3-column theory? It's rubbish. There are 2 columns in the spine, the ventral column and the posterior column. There's no anatomic logic or biomechanical correlation to this middle column that Francis Denise brought up. Forget about it. Anterior, posterior column, that's all there is needed. The ventral column handles compression, the posterior column handles distraction, period. So an unstable burst fracture has patients with loss of body height, neurologic compromise. They don't do well with an up and down, and we can talk about how to do surgery on these with straightforward technologies that you'll hopefully feel more comfortable after injury. Now, Anthony was outstanding in immediately picking up this injury category, which in our country is one of the most overlooked injuries there is. Flexion distraction injuries, or its close cousin, chance injuries. What are they? They look like a compression fracture in the front, but the big difference is, as Anthony said, the PLC is torn. Either ligamentous or bone or both. Chance injuries don't even have the compression fracture. A chance injury just has an angulation of the vertebra. A flexion distraction injury has a compression in the body. So the instant axis of rotation of FDI is in the body, and the chance injury is in the front. Where do you see this? Classically in falls, motorcycle flips. In kids, you see it with lap belt injuries. The pernicious aspect is that they can have a neurologic injury that's way higher than the skeletal level of injury. The other thing you want to think about is hidden abdominal injuries, and they're not even manifest right away. They can come up several days later. It's nothing that you missed, but the serosa of the abdominal contents can necrose due to the contusion trauma several days later when they don't have a bowel movement, and then perforate. This is a very big thing to remember when you see these injuries. Examine, and we published a paper on that, examine their abdomen, check for any stripes. If they have a strip going across, this is a problem because they are at risk for secondary abdominal perforation later on. And re-examine them because they may have a much higher neurologic level of injury. We've seen patients who could move their legs just fine and had absent bowel and bladder control. Why? They actually tore out their central sacral plexus from their conus medullaris anchor through these injuries. So these are pretty nasty. And do remember that when we see images in our casualty departments, they do not reflect the actual deformity at the time of injury. Just like in extremities, most of these patients rebound to some degree due to the soft tissues. So the injuries at time of injury are usually way worse than what we see later on in the X-ray departments. So this is a great application for the rare circumstance of AP images being helpful. If you look at this carefully, there's a big gap where this red line is. That's something that an AP X-ray helps you for. Does this warrant getting AP X-rays on everybody? I don't think so, but it's certainly something to consider. And going back to Anthony's test, you want to see these patients, you want to palpate them, you want to make a mental note about that, you want to teach it, which is even more relevant. And you don't need a MRI scan to see this. You should pick this up clinically or by conventional imaging. Finally, we have fracture dislocations, and again, those are probably the most severe injuries. How can we identify them? On front and side views, on AP and laterals, the spinal column is out of line. And these are globally unstable. These are type C injuries, and they're pretty much a neurologic nightmare. They're very commonly neurologically impaired. If they're not, they're at risk for it, and they do require some form of surgical reconstruction. So that's basically in a nutshell the suggestion to just have an international common basis, no complex alphanumeric sequences that you have to try to remember. This is very teachable also. This is something that I think makes sense, and everybody around the world can correlate to that. And the reproducibility is very high. The publishability, if you want to publish on that, is also very high. So that's kind of my main summary. What matters is neurology of patients. What matters is identify systems injuries. We, even as orthopedic surgeons, have to know what's the head like, what's the chest like, what's the abdomen like. This will affect what we do for the spine. What is the integrity of the PLC? And then assess stability. The test that I just mentioned, the recumbent upright test, see how a patient does. You'll be surprised in some patients, and other patients you'll get a lot of additional insight if you do this very simple mobilization test. Compare before and afterwards, under your own eyes, be an observer. 4 things you can't recover, we'll go about that later. Again, revisit that thought. The stone after the throw, the word after it's said, the occasion after it's missed, the time after it's gone. So those are the basics of this.